All right, inflammation, your favorite and mine. Okay, so quick review of defense mechanisms specific to the CNS. Microglia, remember, are your resident phagocytes. It's kind of all you've got. You can get migration of cells from the circulation as well in circumstances of inflammation. The blood-brain barrier is a major defense mechanism, not just for pathogens, but also for small molecules, potential toxins, the drugs we're trying to give. That's an important point. Blood-brain barrier, remember, is composed of vascular endothelium, which has tight junctions, unlike other places in the body, so nothing gets through without permission. Capillary basement membranes formed by these endothelium, and then the foot processes of astrocytes actually wrap all around the vessels and form the most active part of the blood-brain barrier. So this is where a lot of active transport occurs. And there's a very similar barrier called the blood-CSF barrier located at the choroid plexus. This is where you produce CSF, remember, from plasma, so the filtration there is very tight, similar, have to have a similar barrier to entry. And the basis for neurotropism of organisms is the ability to breach these different barriers and bypass the defenses that we've put up. So again, quick review of blood-brain barrier. It's composed primarily of endothelium with tight junctions, unlike most capillaries in the body where you want things to be a little leaky so things can get in and out. Tight junctions, only permeable to lipid soluble molecules, things that are actually, this is like approved transport by the cell, like I'm actually going to take you from side to side because you're okay. So we have to depend on lipid solubility of drugs, things that the cell has transport mechanisms for, or rely on some other mechanism to open this junction up, like so. So these are some things that crack open that blood-brain barrier. During inflammation and infection, vessels here become like anywhere else in the body, and they become leaky, and that's when we get CNS edema. So inflammation is a major thing that'll open up the blood-brain barrier and make it more permeable. I already answered my own question, so implications for drug administration, especially things that you want to get into the brain. If you have things like a brain infection or a neoplasm that you're trying to get chemo in there, this has a lot of implications for the drugs you choose and the mechanisms of those drugs. Things that are lipid soluble, things that the cell has pumps for, stuff like that, or you have to rely on, giving radiation concurrently, like in the case of brain tumors. All right, some specifics of inflammation in the CNS. Again, vessels here act like anywhere else in the body, so they will become leaky, increased vascular permeability, leakage of plasma leading to edema. And this aspect of inflammation in the brain specifically often hurts more than helps because of that increased pressure. You also, during circumstances of inflammation, get migration of white blood cells from the circulation to come and help out these little microglia in here who are like, oh God, this is too much for us, help. I think I mentioned this the other day, their migration into the actual inflamed tissue is hindered by the density of this neuropil. All the pink is neuropil. So that's like tangles of like dendrites and other cell processes and stuff. So they come out of the vessel and there's like a big pile up here, and that's called a perivascular cuff. So when we see that histologically, that's a hallmark of inflammatory, often infectious disease in the brain. Gliosis is another change. So that's when you get activation of these resident microglia and they proliferate and become activated. We already talked about how glia are activated to become hypertrophic, but microglia are activated similar to other macrophages in tissues, and they will increase in number, and we call that gliosis. All right, so stereotypical responses to infectious agents. Bacteria, like anywhere else, is usually going to be suppurative. So pus, always think bacteria. Occasionally it's granulomatous or pyogranulomatous, sort of depending on different characteristics of the organism. Higher bacteria tend to cause more granulomatous or pyogranulomatous. And bacterial infections, because they're associated with suppurative inflammation, which is very enzymatically destructive. Neutrophils have all those digestive enzymes. This is often seen with quite a bit of malacia. So pus and malacia, think bacteria. For fungal infections, like anywhere else, granulomatous plus or minus neutrophils. Some things are suppurative. Often also causes a lot of malacia. Fungal infections are typically quite destructive and induce a lot of inflammation. So these can also have foci of malacia in them. Viral infections, these are going to be non-suppurative. So non-suppurative is everybody but the neutrophil, right? Lymphocytes, plasma cells, macrophages. These are the infections that are not going to be so grossly apparent. Grossly, you're not going to see anything. You're going to need to get down microscopically and see those perivascular cuffs of lymphocytes, the nodules of glia in the brain, and none of that's going to be visible grossly. So these are often grossly boring. However, viral infections, this is the class of things that causes what I call bonus effects. So things like persistent infection in pestiviruses, congenital malformations like the ones we talked about on the first day, hydranencephaly, porencephaly, cerebellar hypoplasia. So the brain might not look inflamed, but if you have these bonus effects and neuroscience, that might point you down to thinking, all right, I might be dealing with a virus. And then parasites, of course, eosinophils, because that's how they do. However, there are several parasites that will insist in the brain and not result in hardly any inflammation. And the major lesion is just a space occupying effect from the actual parasite. Ew. Routes of infection. So there's three major routes that I could think of. It can come from the head holes. So that's extension of inflammation from anywhere else in the head. These in particular seem to be common offenders. So through the sinuses, especially in large animals, through the ears, especially in small animals. Always the eyes are an option because they're direct extension of brain and meninges basically through the socket. So a little scary. Nasal cavity, especially the caudal nasal cavity, the cribriform plate is right there. So things can invade back and through that way. Guttural pouch, of course, because it's an air hole in the middle of your head just waiting to get infected, surrounded by important nerves and blood vessels. Stupid horse. From the blood, always an option. So systemic infections, things that can bypass the blood-brain barrier. So things that have specific tropism for the brain. And then this is an important category, these Trojan horse organisms that are actually carried into the brain by trafficking white cells that are infected. And finally, probably the most fascinating and scary to me is this retrograde axonal transport, which is where a neuron through a distal axon finds something and like, oh, that's interesting, and like takes it up and it's like, I should show this to the cell body. And they pass it all the way up the neuron to the cell body. And the cell body is like, shit, this is rabies, put it back. So it's unclear to me what the advantage of this is of just like picking stuff up and like passing it along. But that's how organisms have neurotropism and evade the immune system. They're sneaky like that. All right, Jake's back. So you go to your clinician and you tell them your neuroanatomic localization, which if you recall was primarily brainstem with maybe some cortical signs. They're very impressed with your neuro know-how. However, they ask about your other physical exam findings and you realize that in your excitement to do his neuro exam, you forgot to do the rest of your physical. So it happens, it's okay. We've all been there. Actually, you guys haven't been there yet, but you will be like, oops, forgot to do a TPR because I was so excited about his brain. So you do your quick physical. The patient is now febrile and obtunded. You guys know obtunded. It's one of my favorite neuro words. Boo. The animal is also now hypersalivating. You can kind of see some of that in the picture. And he seems hyperreactive to touch. So he's very twitchy when you go to touch him. During your exam, you place your hand on his back and you're trying to take a temp, and all of a sudden he kind of bucks back and he flings his head back and his hyper salivatory spittle just goes everywhere and it showers all over you and you're like, ugh, it's only Tuesday. So you go back to the tending, you tell him about the fever and the new strange behavior, and he seems kind of concerned, and he says, we should get some additional historical information, I think, just to be safe. So he sends you back to talk to the owner. What are your questions now? Yes. Have they had any contact with wildlife? Excellent. Why? What are you thinking? Rabies. So what might be a more pertinent question? Are you vaccinated for rabies? Yes. Also, have you had, that'd be the second question. If they're especially not vaccinated, have they had any contact with potentially strange acting wildlife? Have their neurons picked up anything suspicious lately? So good. This history and these findings should trigger alarm bells, especially if you don't have a vaccination history on this animal. So quick, go get one. So rabies is the #1 most important rule out of all time for CNS presentation in any mammal. Not because you're going to see it all the time, but because it's 100% fatal and it is zoonotic. And any mammal can be affected. So this is one that always has to be right in the front of your mind, even if you never see it. Must remember. Don't become like human MDs. They forget this one all the time. So when they do actually see rabies, it takes them a while to diagnose it because they're like, oh yeah, infectious disease exists. Sorry, I'm extra sassy today. The other critical thing about rabies is there are lots of wild reservoir hosts. Depending on which area you're in. I've got a slide on that coming up. But these different reservoir hosts can be pretty significant places for animals to catch rabies. Again, even if it's uncommon, this always has to be in the front of your mind for a neurologic mammal, especially cortical brainstem signs, abnormal behavior, especially if it's a wild animal, especially if they're unvaccinated, especially if they had contact with a wild animal, or if there has been human contact. So if there's a bite, rabies, right there, gotta think of it, gotta rule out rabies. Important note, have you guys had like a rabies, the World Rabies Day? Do they still do that? So I actually didn't realize before vet school how common rabies was in the world, like how many people it kills all over the world. Most of these deaths are dog carried rabies. So again, in this part of the area, this part of the world, not super common, but still major cause of death worldwide, super important. Here's kind of showing that. So here's dog mediated is more common, especially in Africa, parts of Asia, and then wildlife rabies. We've got quite a bit over here, but you can see multiple parts of the world. It seems like you've got either or, right? If you've got dog rabies under control, then you've got crazy wildlife rabies everywhere that you can't handle. Out here, it's mostly bats where I come from. On the other coast, it's mostly raccoon rabies. In the middle, it's mostly skunks. Important note about bats and sleeping people. Have you heard this one yet? So if you wake up with a bat in your room, test it for rabies, get your prophylaxis because bats bite people in their sleep and they don't know it. It's a thing that I've been told. Could be urban legend. But just to be safe, if you find a bat in your room and you've been sleeping, yikes. Also, if a bat's out during the daytime and bites you, if anything bites you ever.
Out during the daytime.
If a person bit me, I'd probably try to chop their head off and send it for rabies. Like, not okay. Pathogenesis of rabies, transmitted by bite and saliva, starts the process. You do get an initial replication bout at the site of inoculation, and this is what results in the longer incubation period. In general, the farther away you are from the head and face, the longer the incubation period, sort of. Just kind of a general rule, don't take it to the bank. But in general, a distal limb bite is better than a face bite, right? Because it's right there. So it does this initial round of replication, and then the axon picks it up and is like, oh, this is cool. I should show the neurons. And it goes retrograde axonal transport up to the cord, so totally bypassing the whole immune system, all our barriers we put in place, now pointless, gives it to the cell body, and the cell body is like, oh my God, what have you done? And then it starts replicating, and the next axon is like, ooh, that's cool. What's this? And it picks it up, and it's like, I'm going to the brain. So that's how we get to the brain and brainstem. Rabies actually moves up the cord. It does more replication here, so it's amplifying all the way it goes. Gets to the brainstem, comes out the cranial nerves into the salivary glands, and is transmitted in saliva and shedding. Another important thing that's not on this slide is rabies also has a preference for the limbic system, which controls your behavior. So it facilitates its spread by causing abnormal behavior in infected animals, hence all the frothing and spitting and fear of water is another thing it causes, because it wants you to keep drooling and spitting, not rinse out your icky rabies mouth.
Going along with the limbic system, so last year they sent out this video of this goat with like abnormal vocalization that had rabies. Is that just a goat thing? Does that happen with other species?
So remember, I'm not a clinician and I don't actually see live animals ever. However, I know that's still due to like brainstem, because you've got cranial nerves, lingual, and hypoglossal, and whatever they are in there. So that can be a sign of brainstem dysfunction. You get a dysfunction of other cranial nerves, but the place it's trying to get is to the parotid and salivary and out through a bite. Trying to, yeah.
I might have missed it if you said that already, but where the rabies virus goes into the spinal cord and it's multiplying, are you going to see a lesion there?
I don't know. We don't look there. We have characteristic places that we look, and this is not one of them, because at this point, the animal may still not be showing clinical signs, right? Depending on where this is in the cord. Clinical signs happen once you get to the brain and brainstem. And once a virus starts replicating in the brain, that's when you're dead. Okay, so important things clinically. You get viral secretion in your saliva before the onset of clinical signs by a few days. And this is why we have that magical 10-day waiting period, right? Because the assumption is that if you are shedding at the time of the bite, you will develop clinical signs within several days. That's the principle for the 10-day rule. Does that make sense? So by the time you're shedding in your saliva, it's in your brainstem, it's in your cranial nerves, and it's just got a couple more days to go. So if they bite somebody, they will show signs within a few days if they are rabid.
You're not a clinician, so I changed my.
Change your mind. I realized it was hopeless. You won't be able to answer my question. Clinical signs. The animal will go from subclinical to clinical.
So like salivating to like
abnormal behavior. Yeah. Okay. This might be before hypersalivation. Because I would assume hypersalivation is a clinical sign, right? So shedding before hypersalivation, probably. If you get bitten by an animal that does not seem rabid, you've got a couple days to wait, see if it's going to become rabid or not. Again, kind of implied by this, the clinical course of rabies is acute and short. Once it gets to the brain and brainstem, it's going to kill you very rapidly. You'll get development of not just abnormal behavioral signs, but systemic signs, weakness, paralysis. This is associated with spread in the brainstem, difficulty swallowing due to paralysis of the tongue, and all this extra drooling aids the spread of the virus. Yeah.
So you said that it will like incubate in your system for a few days.
This is slow. So the incubation period of rabies comes from this step, replication, this migration step, the second replication, this third migration step, and then once you get to brainstem and brain, you become clinical. You start shedding right before you become clinical. Within a couple days, you will develop signs because the virus is in your brain and brainstem. And shortly after you develop clinical signs, you will die. Did that answer the question? Yeah. Slowish. By the time it gets here, everything after that goes quick. Furious and dumb forms, they aren't really different. There's nothing different about the infection. It's just some animals manifest differently. There's also a paralytic form due to this brainstem spread and weakness. But furious is when they're, crazy and frothing, and dumb is when they're kind of in the corner with their head pushed in. All right, so pro tips for rabies. I'm sorry I can't give you clinical pro tips for rabies, but I can give you pathology and diagnosis tips for rabies, because that's what I do. So there are no gross lesions of rabies. This is always a post-mortem diagnosis. We need the head. I'm sorry, you cannot anti-mortem diagnose rabies. We need brain tissue. So testing is performed on fresh brain tissue. Don't send it fixed, please. Will leave us with less options. And we do immunofluorescence. So here is an image of brainstem, and all the green is fluorescently tagged antibody against rabies. So this would be a positive sample. There's a lot of rabies in this brainstem. We also do histopathology and look for these characteristic This is wrong. Oh no, that means this is the old PowerPoint. Ah, that's okay. We'll just go with the mistakes. These are intracytoplasmic neuronal inclusion bodies. Good. For small ants, sorry, that one mistake throws me like all up. I'm like, I should just go home. For small animals, it's best to send the whole body to us if you can, and this will minimize any human exposure. We don't advise people to cut off the heads on their own and send it unless it's a large animal, because we would rather not deal with the whole animal. If you can, send the whole animal. If it's difficult, you can just send us the head. Make sure it's, double, triple, quadruple bagged, not bleeding everywhere.
Large dogs, like really just send like 100-pound dogs.
The goal is minimizing human exposure if you truly think this is a rabies suspect. So I would say always better safe than sorry, always best to send the whole body and not open it. Then again, we deal with what we can. So sometimes we get heads. Sometimes we get live animals. Please call the lab and make sure they accept live bats and other things, especially before you send them, because if we get a live bat, we will give it back to you and be like, we cannot, I'm sorry. We don't euthanize animals here. Some labs do, so check with the lab. Please, please, please do not euthanize these animals with headshots. Get so many of those, and it's just like animal with neurologic signs euthanized with a shot to the head, and I'm like, I can't help you. Garbage in, garbage out. Yeah.
So if we're like a horse or a cow suspect of rabies, or do we have to test them?
Yep.
What is like cleaning the environment look like? Does rabies survive for a long time?
It does not survive in the environment. It is cell associated, I believe. So yeah. And good advice for anyone, if there's been a human exposure, contact the local health department. Don't take them to the vet, even though they're begging you. Okay, so backing up to rabies, there's no gross lesions. So diagnosis, we need fresh brain tissue. This is postmortem diagnosis only. And what we're looking for on histopath is, we call them Negri bodies. They are eosinophilic, and this was wrong in the original PowerPoint, but they should be intracytoplasmic, not intranuclear. And they're inclusion bodies in neurons. So those are little clots of like viral protein replication, basically. Locations are specific to species. So in carnivores, we see these Negri bodies most often in the hippocampus. In herbivores, we see them in the cerebellum. So these are kind of the preferred samples. But honestly, you're probably sending either the whole head or the whole animal or the whole brain. So you don't have to worry about it. We just need the brain. Talked about that. No headshots, please. Good in video games, not good in rabies cases. So these are what Negri bodies look like. So this is a neuron right here, very large cell body, huge nucleus, cytoplasm out here, and all these big dark red blobs in the cytoplasm are Negri bodies. Here's one. The staining is a little bit different. So these are both the same stain, but they're a different lab, so their procedures are a little different. Some things stain a little more red. This one's actually a better stain in my opinion. So here's the neuron right here. Here's the big nucleus, all the cytoplasm, and it's got this one big goober of an inclusion right in the cytoplasm. Negri bodies. Good question. So they're intraneuronal, they're intracytoplasmic. They're only intracytoplasmic. So there are other things that can do that, technically. I don't have a great answer for that. That makes it a really good question. It's kind of just a Negri body is just the inclusion of rabies. I don't know that you could specifically tell a Negri body from another inclusion by looking at. So that's why we've also performed this immunofluorescence. So that's actually testing for the viral antigen. So if we saw this, we would be highly, highly, highly suspicious of rabies. So that's what this is. If you see intracytoplasmic, intraneuronal inclusions, that's a rabies red flag. Distemper can also make intraneuronal, intracytoplasmic inclusions. However, the weird thing about distemper is it can do intranuclear and intracytoplasmic. So if you see them in both places, you'd be like, that's not rabies. That's probably a paramyxovirus. It's distemper.